So my name is Anna. I'm a first year PhD student here at the University of Bristol. I'm part of the Centre for Academic Primary Care, and my PhD is looking at health inequalities in primary care. And specifically, I'm looking at the relationships and the interplay between ethnicity, antibiotics, and respiratory health outcomes. So my PhD kind of falls into four kind of sections. So the first one is the background, like understanding what actually is the problem, what are we trying to address. I'm doing a qualitative study, so that's interviews with doctors and with patients. I'm also doing a quantitative study, so that's like a statistical analysis of healthcare records. And then I'm also doing patient and public involvement. So first of all, and pathogens, or our examples are bacteria, viruses, fungi, parasites, and antimicrobial resistance, or AMR, results from genetic changes to these pathogens so that they no longer respond to antimicrobial medicines. And this happens naturally and is normal. However, human activity exacerbates the problem. So increased exposure to antimicrobials, such as antibiotics, causes us to develop more resistance. An example of way that this happens is through inappropriate prescribing of such medications. And antibiotics, as I said, are the most commonly used antimicrobials, and they're used to treat bacterial infections. So the main concerns regarding antibiotic resistance is, well, it's an internationally recognized threat to public health. Um, a bacterial antimicrobial resistance, or like antibiotic resistance, is directly responsible for 1.27 million deaths in 2019, and it's contributed to almost 5 million deaths. And these are World Health Organization estimates. 80% of all antibiotics in the UK are prescribed in primary care. So therefore, this is an issue that we need to address in primary care. We need to solve this problem. And the most common kinds of infections that happen or that are seen in primary and secondary care are respiratory infections. So we always hear that antibiotic resistance and AMR is a problem, but why actually is it a problem? Well, it's a problem because the infections that happen are often more severe, they last a lot longer, they result in more consultations and more antibiotic treatment. So, which is one, obviously, well, fundamentally not good for the patient. No patient wants to be going through this, but it also is a massive burden on our healthcare system. It results in increased costs, and therefore it's a growing cost that we need to try and reduce. It results in more hospitalizations, and specifically in secondary care, the duration of hospital stays are longer and mortality is increased. So health inequalities are differences in health, access to healthcare, and quality of experience between different groups of the population. However, health inequities are differences which are unjust, avoidable, or rooted in discriminatory policies. And as a society, we can attempt to reduce inequities to improve health. We can try and reduce the discriminatory policies, the systematic changes, but we can't, it's a lot more difficult to reduce inequities. And a key example of this, which I'm just going to briefly touch on, is the example of sex. So women live longer than men. There's a higher life expectancy in women. And say that this was due purely to biological reasons, that would be a health inequity. That's not caused by us treating women differently to men. It will be a biological difference. However, if women lived longer than men because of, I don't know what's example, like say women receive better quality of healthcare than men, that would be a health inequity. That's something that we can try and change as a society to reduce that discrepancy in life expectancy. So there is evidence of between different ethnicities there being differences in health outcomes in primary and secondary care. And health inequities tend to have a disproportionate impact on people from minority ethnic backgrounds. And there is some evidence specifically of people of certain ethnicities experiencing poorer respiratory health outcomes. Therefore, this is an inequity that we need to try and resolve. And an example of this, just briefly mentioned, is COVID-19. People of certain ethnicities suffered with COVID-19 more severe health outcomes. So when we look at ethnicity and antibiotic resistance, we really don't know a lot. It's not a very well understood relationship between the two. But I've just taken this section of a report that was conducted in 2022 to 2023, which was looking at the presence of antibiotic resistant bacteria or bacterial isolates in blood of people. And the rate of antibiotic resistance being present in the white population was 4.1%. However, the rates in the Asian and the Black ethnicities was higher than this, and these were statistically significant findings. So there was more antibiotic resistance present in these minority groups. However, and also just something to note, like as you get older, you're more likely to experience infections. So you would assume that the antibiotic resistance levels would be higher in people of older demographics. But the white ethnicity group, the mean age of that group was 69. It was almost 70, which was older than both of these minority groups they've highlighted. So therefore it kind of shows that there is actually a difference between ethnicities, because even in spite of this age difference, the rate of antibiotic resistant bacteria being present was still higher in the minority groups. So we currently have we have no solid evidence as to how our use of antibiotics as a society is contributing um, to these relationships between ethnicity and health outcomes. So we understand this relationship. We understand you have antimicrobial resistance or antibiotic resistance. Therefore, you develop worse infections. You're treated for the infections, oftentimes with more antibiotics or different antibiotics, feeds back into the antibiotic resistance being developed. Like it's a relationship that both interplay with each other. But we don't know really how ethnicity plays into this. So it's these relationships between ethnicity and antibiotic resistance and ethnicity and the respiratory health outcomes that I'm going to be investigating and looking at. So I'm basically going to be trying to understand and quantify these associations between respiratory health and antibiotic prescribing for illnesses, like in different ethnicities. So this study will allow me to try and understand more if antibiotic prescribing is what's driving this difference in respiratory health outcomes in certain ethnicities. And therefore, by trying to help identify the problem, we may be able to find avenues to potentially try and fix this, to try and reduce the health inequity that it currently exists. So that was me just talking about the problem. I'm just going to very briefly run through what I'm actually going to be doing to try and understand this situation. So the first is my quantitative study, which is like my numbers statistical analysis part of my project. So I'm going to be using a data set called the Bristol, North Somerset, South Gloucestershire system-wide data set, which is basically a anonymized patient level data set which encompasses primary and secondary care data all into one thing, which basically allows us to look at how people travel through primary care into secondary care and analyze the whole healthcare system as a whole rather than looking at just primary care or secondary care in isolation. So the kinds of data that I'm going to be looking at in that is like antibiotic prescribing, like what antibiotics or what medicines are people given, how often do people end up going to the GP or to A&E, for example, and then how often people are admitted into hospitals. So I'm just basically going to be looking at those relationships and interplay between those sort of factors. I'm also going to be doing a qualitative study, which is going to be interviews. Going to be talking to people, finding out what they think about this problem and what are their experiences. So I'm going to be doing interviews with up to 30 patients and up to 30 doctors who serve these communities. And the kinds of questions I'm going to be asking are about what's your experience of having consultations? How has it been? Do you feel heard? Do you feel that you can convey what you need to say? Those sort of avenues or questions. We're going to explore whether people have any problems, whether can they get to the GP? Do they feel like they're given the right treatment for what they need? Do doctors feel like they're able to deliver the healthcare that they want to deliver? Um, if my statistical analysis does discover that there's any sort of differences between ethnicities in prescribing, I will use my qualitative analysis, my interviews, to basically uncover why this is. Like, why do you think this is? And finally, I'm going to ask participants their views on what they think we can do to reduce these health inequities or health inequalities if my statistical analysis does find out that they do exist. So I'm also going to be conducting PPI, or patient and public involvement. And PPI is when research is carried out by or with the community rather than just researchers doing it on behalf of the community. And it's really vital to actually ensure that your research actually applies to the population that you're investigating. And as historically ethnic minorities haven't been included in research, PPI really helps to combat this and ensure that everyone's heard and everyone's voice is everyone is heard, everyone's voice is heard regardless. And that basically that all our findings are actually applicable to everyone, not just the people who have historically been involved in research. So I'm going to be creating my own PPI advisory group, which will be a group of around 6 individuals of African or Asian heritage, all sexes, all genders. And this group will meet with me every 2 to 3 months roughly, but it will be clustered. I guess it will be around key points within my project to help guide me. So things that they'll be helping me on is interpreting what my statistical analysis actually finds, relating it back to the population. They're going to help me with creating my my list of questions I'm going to be asking in my interviews. They're going to help me relate the statistical findings to the interview findings, make them actually be a cohesive answer. And then this group is going to help me in getting my findings back out to the population, to the people that it actually matters hear this information. So thank you very much for listening to me. And does anyone have any questions or anything they'd like to discuss with me about it?